So we start in 3, 2, 1.
Faculty members, and good morning to all who have joined from western side of the world and all participants who have joined from India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Hani L. Samkari, all discussants and participants to this virtual symposium on hereditary hemorrhagic telangiectasia advances in therapies. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a well-respected and humble senior hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Hani Samkari from Boston, Massachusetts, USA, and he's going to lecture us on hereditary hemorrhagic telangiectasia advances in therapies. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Hani Samkari from Boston, Massachusetts, USA. All our discussants who are themselves very eminent hematologists, and you participants for spending the Saturday evening, morning or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 1st of September 2024 from 11:30 a.m. Indian Standard Time and 8 a.m. French time, we have Dr. Regis Latour from Paris, France, speaking to us on non-transplant treatment of aplastic anemia. Let me introduce our discussions for the day, and here is played in alphabetical order. To start with, we have Dr. Abhijit Giram from Sahyadri Hospital, Pune, Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad, Dr. Akash Khandelwal from Action Cancer Hospital, New Delhi, Dr. Anand Kumar K from Sparsh Super Specialty Hospital, Bengaluru, Dr. Aniket Mohite from Jahangir Hospital, Pune, Dr. Archit Bandari Pandey from Postgraduate Institute of Child Health, Noida, Uttar Pradesh, Surgeon Commander Dr. Arun V.A. from INHS Aswini Kolaba, Mumbai, Dr. Cecil Rose from St. John's Medical College Hospital, Bengaluru, Dr. Deepjot Pusti from Institute of Medical Sciences and Some Hospital, Cuttack, Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj, Dr. Gopinathan M. from MGM Healthcare, Chennai, Dr. Hamza Dalal from Fortis Hospital, Mulund, Mumbai, Dr. Kripa Bajaj from KIMS Hospital, Hyderabad, Dr. Kunal Chatani from Nagpur, Dr. Mukul Agarwal from AIIMS, Delhi, Dr. Pritish Chandra Patra from SOA University, Bhubaneswar, Lieutenant Colonel Dr. Ranjit Matthew Varghese from Command Hospital, Pune, Dr. Sandeep Nimani from Sri Siddhi Vinayak Ganpati Cancer Hospital, Miraj, Dr. Satish Kumar A. from Manipal Hospital, Bengaluru, Dr. Sud Prakash Sanyal from Fortis Hospital, Mumbai. Now it's time to introduce our guest speaker for the day. We have with us Dr. Hani Samkari from Boston, Massachusetts, USA. Dr. Hani is the Peggy S. Blitz Endowed Chair in Hematology Oncology at Massachusetts General Hospital and an Associate Professor of Medicine at Harvard Medical School. He's a classical hematologist, an NIH-funded clinical investigator, and clinical trialist. He also serves as co-director the MGH Hereditary Hemorrhagic Telangiectasia Center of Excellence. His clinical and research interests are in hemostasis, thrombosis, and hemolysis, with focus in HHT, immune thrombocytopenia, and hemolytic anemias. As a clinical investigator, he is an internationally recognized expert in the clinical development of novel therapeutics for these disorders and serves as a lead principal investigator for multiple ongoing clinical trials. He is a current executive editor of Hematology, the ASH Education Program, an American Society of Hematology peer-reviewed publication, and has published over 150 peer-reviewed manuscripts. His original research has been featured in the New England Journal of Medicine, the Lancet, Annals of Internal Medicine, and Blood, among other top peer-reviewed journals in hematology and medicine. And today he's with us and he's going to lecture us on hereditary hemorrhagic telangiectasia, advances in therapies. Well, thank you so much. Over to you, sir.
Wonderful. Thank you so much, Dr. Khurana. Let me just share my screen for my slides. All right. Can you confirm that you can see my PowerPoint
Perfect, sir.
slideshow view?
Absolutely perfect.
Yes.
Please go ahead, sir.
All right. All right. So I just want to start by thanking Mumbai Hematology Group, by thanking Dr. Agarwal for this very kind invitation, by thanking our all of the eminent hematologists that are serving as discussants for my talk today. I think we'll have a very nice question and answer session after the talk. It's just really an honor to be speaking to such an eminent group of hematologists as well as such a large audience. So it's really my pleasure to be here today. So title of my talk is Hereditary Hemorrhagic Telangiectasia, Advances in Therapies. Here are my disclosures. So I'd like to begin because when we talk about inherited bleeding disorders, we really tend to think about coagulation factor problems. They're the first that come to mind. And there's historical reason for this, but I tend to think about the spectrum of inherited bleeding disorders slightly differently, and I encourage you to think about inherited bleeding disorders similarly as well. So on one end of the spectrum, we have the pure coagulation factor problem, of which the prototypical disease is hemophilia, which affects 1 in 10,000 people. Patients with hemophilia have normal angiogenesis, normal blood vessels. On the other end of the spectrum, we have vascular structural problems, of which the prototypical disease is HHT, which affects 1 in 5,000 people. In the middle of the spectrum, we have the most common inherited bleeding disorder, von Willebrand disease. Most cases of VWD are relatively mild compared with hemophilia and HHT. VWD results from deficiency of a coagulation factor, of course, von Willebrand factor, but von Willebrand factor is also critical in angiogenesis, thereby resulting in disordered angiogenesis. And this is why we can see patients with von Willebrand disease, and really it can happen with any type of von Willebrand disease, who develop angiodysplastic lesions, angioectatic lesions in various locations in their body, in particular the gastrointestinal tract, and they can look very much like patients with HHT. And so, when we think about inherited bleeding disorders, don't forget that it is a spectrum. It is more than just coagulation factor defects. So I know the audience here is well aware of HHT, but just as a reminder, in case you don't see lots of patients with HHT on a regular basis, HHT is a multi-system hereditary bleeding disorder with numerous morbid and potentially fatal manifestations. It is not simply a hereditary nosebleed disease. These patients have mucocutaneous telangiectasias that cause chronic gastrointestinal hemorrhage and severe recurrent epistaxis. That results in severe iron deficiency anemia, which can be iron infusion and red cell transfusion dependent. Most patients have visceral arteriovenous malformations, most commonly in lung, liver, and brain. These can result in a whole host of other complications: high output cardiac failure from liver AVMs, same with liver disease and cirrhosis from ischemic cholangiopathy and other liver complications, pulmonary hypertension and pulmonary hemorrhage from lung AVMs and lung manifestations, hemorrhagic stroke, transient ischemic attacks, epilepsy, and sudden death from brain AVMs. Despite all of this, we've surveyed many hundred patients with HHT, and we ask them what causes the greatest morbidity, the greatest clinical impact of your disease, and it's bleeding. Bleeding is number one by a large margin, because all of these patients have bleeding, and the bleeding gets worse over the course of their life, and it causes major psychosocial complications. There are no licensed therapies anywhere in the world for HHT to date. So, there's certainly work to do, and I'll talk about, the theme of my talk is advances in therapies, and we'll talk about how things have advanced over just the last few years. So HHT, as I mentioned before, second most common inherited bleeding disorder. Autosomal dominant. So when you see a patient, 50% of their family members have it. We recognized through some recent work, actually, that this HHT appears to be the most clinically significant and morbid inherited bleeding disorder of women. It's very, very rare for women to have symptomatic hemophilia because it's X-linked. So for every man with hemophilia, there's one woman and one man with HHT. This is not fully appreciated. The diagnosis of HHT is often later in life, unlike hemophilia and von Willebrand disease. People usually tend to be, the average age is people are in their 40s because the manifestations are not severe in most patients in childhood and they get worse over the course of life. We recognize that even though it happens in men and women equally, women tend to have slightly more overall severe bleeding and visceral disease complications than do men, even though, of course, men can have severe disease as well. Patients with HHT have reduced overall survival compared with healthy controls. And, this is, we say it's it's technically a rare disease because it meets the definition of rare disease, but 1 in 5,000 is not all that uncommon. A recent study actually found a prevalence of 1 in 3,800. Likely because, again, diagnosis is not perfect and many patients are being missed. And you have 250,000 patients with HHT in India. So it is, not that uncommon of a disease. In a study evaluating 200 age-matched women with HHT and von Willebrand disease, examining all the relevant bleeding-related outcomes, the likelihood of most every bleeding-related disease manifestation or outcome was higher in HHT, and usually many times so. So, this data that really suggests that HHT is the most morbid and clinically significant bleeding disorder of women, something that hasn't really been appreciated because, again, of the way a lot of us think about inherited bleeding disorders, which is that we think just about the coagulation factor defects and not about the vascular structural problems. And to patients, they bleed, and that's what matters to them. So consistent with this, healthcare utilization rates in this study, specifically to treat bleeding disorder complications, was much higher in women with HHT compared with von Willebrand disease. That's across the board, almost, including rates of hemostatic procedures, emergency department visits, hospital admission, outpatient encounters. This study was done at the Massachusetts General Hospital, which is a center for both HHT and for hemophilia and von Willebrand disease. So similarly, a referral center for both diseases, and yet there's this dramatic gap in healthcare utilization. Just again, a pathologic lesion of HHT is the AVM, or arteriovenous malformation, an abnormal linkage between artery and vein that bypasses the physiologic capillary bed. Telangiectasias are small AVMs up to a few millimeters in diameter that usually occur in skin, GI mucosa, upper aerodigestive tract. AVMs are more than a few millimeters in diameter and most commonly occur in visceral organs and CNS, like lung, liver, and brain. This is relevant, the pathophysiology, both as a reminder and just in thinking about some of our upcoming therapies that we're going to talk about. HHT is a disease of the transforming growth factor beta pathway, which is critical in angiogenesis, in particular endothelial cell proliferation and smooth muscle migration. HHT occurs due to mutations along the ALK1 signaling pathway. All right, so ALK1 is not the anaplastic lymphoma kinase that we think about in lung cancer and in lymphoma. ALK1 is the activin receptor-like kinase family member 1. It's also called ACVRL1. So mutation at any of the steps along this pathway, including endoglin, ALK1, BMP9, or SMAD4, results in reduced signaling through ALK1 and increased signaling through ALK5, which is its partner pathway. And this tilts the balance toward increased VEGF production because ALK5 is normally promotes VEGF production. ALK1 normally inhibits it. So when we lesion ALK1 or that pathway, then we promote VEGF production, vascular endothelial growth factor. This results in formation of abnormal small blood vessels that can then grow. It results in the endothelial cells having abnormal cytoskeletons, making the vessels fragile, making them leaky. There's disrupted smooth muscle migration, which is normally very important in, normal vessel function and in the integrity of vessels. And so we get the vascular lesions of HHT. Now, these are images from patients with HHT, just showing some of the mucocutaneous telangiectasias in skin. These patients have a lot of lesions. You don't need to have, you can have 2 or 3 little telangiectasias that can be smaller than this and make the diagnosis. These patients have quite a few. This is another example of oral telangiectasias, oral cavity, tongue, palate. Again, these are very plentiful. They do not need to be as plentiful in real life. They often aren't as plentiful, but if you see 1 or 2 or 3, that's enough to raise the suspicion. In gastrointestinal tract telangiectasias, we see these can be throughout the GI tract and often are. They're often hidden deep in the jejunum. So they can be difficult to find on scoping, upper endoscopy and colonoscopy. The most common way patients present with gastrointestinal bleeding is with a slowly progressive chronic anemia that's out of proportion to their epistaxis. So, finding the lesions in the GI tract and the patient having anemia out of proportion for epistaxis is enough to say this is likely a patient that has gastrointestinal bleeding. We don't need to see the lesions bleeding at the time of endoscopy. Friable telangiectasias within the nasal mucosa are almost universal, and patients with HHT result in severe recurrent epistaxis, as we know. Over half of patients will develop pulmonary AVMs, maybe asymptomatic, and may present with all sorts of complications, very commonly chronic migraines, but also can cause hemoptysis, dyspnea, hypoxemia, clubbing. Brain abscesses and stroke may occur in patients following dental cleaning or dental work or surgery. If we don't give prophylactic antibiotics, they can get deep-seated tissue infections that can be in brain, in spine, in muscle, in joint capsules. Can be very, very morbid or even fatal. And of course, pulmonary AVMs create a passage for paradoxical embolism of clot to cause strokes. They're often clinically silent. Liver AVMs are found in up to 70% of patients with HHT. In more severe cases, the shunting of blood through these AVMs in the liver can precipitate high output heart failure, ischemic cholangiopathy, chronic liver disease, cirrhosis. They can really cause severe morbidity and mortality. CNS AVMs in brain or spine are thankfully limited to just 10 to 20% of patients, but certainly these are very, very concerning. They can result in hemorrhagic stroke, sudden death, epilepsy, other neurologic complications. So we screen for these AVMs in all patients. HHT, as I just got done telling you, has many manifestations, but again, the patient's rank of bleeding is number 1, and it is the most common manifestation, and it is responsible for the largest amount of morbidity. So patients have multiple nosebleeds daily commonly. If they have more mild bleeding, usually it will progress to more severe over time as they age. It's not uncommon to have an hour or more of nose bleeding daily. And, this results in psychosocial morbidity and an inability to, go to school or work in some patients. They become socially isolated. They don't want to travel. They don't want to see other people. It causes a diagnosable psychiatric condition related to the nosebleeds in almost 50% of patients. And that includes depression, anxiety, post-traumatic stress disorder. And the GI telangiectasias are present in 75%, and half of which chronically bleed. So, and this very commonly leads to a dependence on at least IV iron infusions and sometimes red blood cell transfusions. Not surprisingly, anemia is extremely common. Management of iron deficiency is absolutely crucial in patients with HHT, the vast majority of whom will become iron deficient from bleeding, and most of whom will become anemic if not properly managed. We monitor CBC, ferritin, and transferrin saturation at least once yearly in all HHT patients, and most who have a history of iron deficiency or iron deficiency anemia require it more frequently, like every 2 or 3 months. Remember that HHT patients are chronically bleeding from their nose or GI tract, so Aggressive management of iron status is a cornerstone of proper management and prevention of the misery of chronic iron deficiency or iron deficiency anemia, as well as the increased thromboembolic risk imparted by these pathologic states. Oral iron is not adequate for most patients with HHT who will not consistently reach the goal ferritin listed in the international HHT guidelines of greater than 50 and the goal transferrin saturation of greater than 20% without at least giving the patient some intermittent IV iron to replete them. We recommend not accepting patients, quote unquote, treading water on oral iron, meaning those patients who manage to avoid frank anemia but tend to live at ferritins and transferrin saturations at the low end of the normal, or that are low or lower than our goals. We give them IV iron. We don't hesitate to administer IV iron in non-anemic patients because they will become anemic if you don't prevent it. Some more severe patients will depend on regular IV iron infusions to maintain a normal hemoglobin, which is achievable in the vast majority of patients with HHT, over 90%, even if it means administering a lot of intravenous iron, 1,000 milligrams every month or every 2 weeks. I recommend against, giving small amounts of IV iron when they're being, repleted, when they're frankly anemic. You need to give at least 1,000 to 1,500 milligrams of elemental iron and recheck, typically in 4 weeks. Many of the total body iron deficit formulas, the calculations that we use to see total body iron deficit, like the Ganzoni formula, often fail in these patients because their iron deficit is a moving target. It's increasing. They're continuing to bleed. So, we keep that in mind. I typically will just give about 1,000 to 1,500 milligrams of iron and recheck. When patients are non-anemic, I maintain a ferritin of greater than 50% and a transferrin saturation of greater than 20% to prevent them from falling into anemia by the next time they see me. And I give 500 to 1,000 milligrams of IV iron when that happens. It's very hard to overtreat these patients with IV iron. Now, available IV iron products depend on the country and in many cases specific health system, but it is important to choose wisely IV iron formulation when treating HHT. So, there's one take-home message on this slide, which is that ferric carboxymaltose, which I understand is available in India, should be avoided if at all possible in these patients. Results in a 50 to 75% risk of treatment emergent hypophosphatemia with a single course. And that can last for weeks to months after even just one infusion. There's no way to treat this. I'll explain in a moment. Repeat infusions may result in serious decline in bone density, bone demineralization, osteomalacia, and pseudofractures or insufficiency fractures, which are all preventable if we just use a different IV iron product. Honestly, any of the other products are fine. It's just that, with iron sucrose and ferric gluconate, they're really suboptimal because you can't give very much iron with a single infusion, and it takes a longer time to give those infusions because these are products that are 20 plus years old. Low molecular weight iron dextran is very old of a product, but is a perfectly fine product. This is distinguished from high molecular weight iron dextran, which is associated with high risks of anaphylaxis. Low molecular weight iron dextran is a suitable product and has very low risk of anaphylaxis. Ferromoxetol and ferric diisomaltose are really ideal products because they allow you to give a lot of iron in a relatively short period of time and do not have a high risk of toxicity and don't cause treatment emergent hypophosphatemia. So, this is true for every patient with a chronic bleeding disorder and who receive repeat IV iron. It's not HHT specific. It could be true for patients with inflammatory bowel disease who need regular IV iron, patients with heavy menstrual bleeding who need regular IV iron. Ferric carboxymaltose, or FCM, causes massively increased levels for unknown reasons in a hormone called intact fibroblast growth factor 23, or IFGF23, This powerfully induces hypophosphatemia through urinary phosphate wasting and other mechanisms. And the lesion lasts for a long time, many weeks to months. So even when only relatively mild, hypophosphatemia can cause, symptoms that we want to avoid. We're treating with IV iron because we want to make people feel better. Hypophosphatemia causes weakness, asthenia, bone pain, but it can last so long in these patients that it demineralizes bone. Now, if you are a chronic bleeding patient and you're getting FCM infusions every couple of months, you can be persistently hypophosphatemic, and that slowly demineralizes the skeleton. This can be obviously bad, but I actually personally avoid ferric carboxymaltose in any patient because even a single infusion can cause severe hypophosphatemia, which can cause severe complications like rhabdomyolysis and hemolysis. Giving IV iron is one of our favorite things to do as hematologists. It makes people feel so much better, right? We love that. But let's make people feel much better, not sort of better. Why would we give a patient a product that improves them less? So this was data from the PHOSPHARE IBD trial, a large, well-done, double-blind, randomized controlled trial in patients with inflammatory bowel disease using ferric carboxymaltose versus ferric diisommaltose and FDI. It's also called iron isomaltoside. It doesn't matter what the comparator product here is. It could be any comparator product. It doesn't have to be FDI. And this found that significantly and very clinically relevant lower improvements in FACIT fatigue scores in those patients receiving FCM versus FDI. And amazingly, the difference was essentially entirely explained by the phosphate decrease. Those with greater decreases in phosphate, the various quartiles of phosphate decrease, had lesser improvements in FACIT fatigue. Because again, we're causing hypophosphatemia and all the symptoms associated with it. And it's not just making, patients feel a little bit bad, right? So this is IFGF23 mediated hypophosphatemic osteomalacia pseudofractures, also called insufficiency fractures or Looser zones. These can be painful, very painful, debilitating. And unlike garden variety fractures, which we diagnose with regular x-rays, these are very easily missed on x-rays. So look at panel A. And panel A and B is 45-year-old patient with chronic GI bleeding who had received repeat FCM infusions to treat the iron deficiency anemia. Over time, developed osteomalacia, presented with a painful waddling gait. His x-rays were normal, showing no fractures, but his MRI showed really awful bilateral hip pseudofractures. You see the demineralized bone is that white area in the hip in the MRI in panel B, and then the pseudofracture is that black void going through the white area on both hips. PET CT in these patients and bone scans can also show locations of pseudofractures. And the PET CT scan shows that a different patient had multiple occult pseudofractures in ribs and other bones in addition to having them in the hips. Just as another example, this is a 65-year-old man with HHT who received FCM infusions monthly for 2 years until he was in pain from head to toe, could barely move without pain, was actually wheelchair bound. Bone scan showed diffuse hypophosphatemic osteomalacia pseudofractures throughout his skeleton, including feet, knees, hips, ribs, and shoulders. So again, this is entirely avoidable by just using a different IV iron product aside from ferric carboxymaltose. And this is, just an example of a woman, young woman, 28, heavy menstrual bleeding, got a single course of ferric carboxymaltose, just 1,500 milligrams to replete her. 8 weeks later, she had acute respiratory failure. She was intubated. She couldn't breathe. Her serum phosphate was 0.6, which is dangerously low. And she was just treated with huge amounts of oral and IV phosphate. And again, you can give to these patients all the oral and IV phosphate you want. They'll just pee it out because the lesion is in the kidney. So they just urinate out the phosphate that you're giving them. She also got very high doses of calcitriol. And after a couple weeks, her phosphate finally was able to be normalized. But again, this is totally avoidable just by using a different product. All right, so I'm going to shift gears here and discuss the modern paradigm of treatment for bleeding in HHT. And again, this is where the advances in therapies piece comes in. I talked about iron, which is very important. And, we want to make sure that patients that have epistaxis have, good supportive care with their nasal moisturization regimen, nasal saline sprays, gels, air humidification. So that's part of the care for all patients. But of course, most patients will need much more than this. In the past decade, HHT treatment has really rapidly undergone a paradigm shift from bleeding treatment, primarily done with ablative procedures, to systemic therapies. So there have been numerous important reasons for this shift, but key among them are, number one, the recognition that tissue injury, as is by definition part of ablative procedures, stimulates a pathologic rise in local vascular endothelial growth factor, which is normally rises to improve healing, local healing of injury. And so in patients with HHT, they get a pathologic rise in VEGF. Their normal feedback systems are dysregulated. They produce too much VEGF when they have a stimulus for VEGF. So what are we doing when we're going in and we're cauterizing, or we're lasering, or we're using various local therapies in the nose and the gastrointestinal tract to treat bleeding? We're causing tissue injury. We're actually provoking greater telangiectasia formation after a few months of healing. And that's exactly what clinical data on this has borne out. Patients are not better in the long run when they get these procedures. So, that piece, coupled with the fact that investigation into the safety and efficacy of systemic agents, specifically antifibrinolytics and, more importantly, anti-angiogenic drugs to treat bleeding in HHT, has been quite successful. For patients with acute unstable bleeding who present to the emergency department, give them an IV antifibrinolytic bolus. And if the bleeding does not cease, this is a good time for a local ablative procedure in the nose. Okay, you got to do what you got to do in an acute setting. Patients presenting to the ED with profound anemia due to gastrointestinal bleeding, this is the time to do the endoscopy, perform argon plasma coagulation or some other means to achieve hemostasis on the actively bleeding telangiectasias. But most patients with HHT, right, they present to the clinic with chronic stable bleeding, including epistaxis and or gastrointestinal bleeding. And the next step is to determine their bleeding severity, and then based on this, proceed to proper systemic therapy. Assessment of bleeding severity HHT is really quite simple. Okay, I assess 3 independent domains. The first is the objective epistaxis severity measurement, which is performed with a validated epistaxis assessment tool in HHT. Okay, and most frequently, this is the well-validated and quite simple epistaxis severity score, or ESS. Second is the objective hematologic support requirements that the patient has needed to achieve and maintain a normal hemoglobin. Do they require oral iron or dietary iron only? That would be mild. Do they require intermittent IV iron? That would be moderate. Do they require regular IV iron or red cell transfusions? That would be severe, all right? And lastly is the subjective patient report of the impact of epistaxis on their life. What is that? This might be minimal. Maybe it's a minor nuisance. Yeah, I get nosebleeds every once in a while. It doesn't cause me too much trouble. Or maybe it might limit their actions at work or their social life, causing some emotional, social, or financial distress. That would be moderate. If it renders them unemployed, on disability, or with a diagnosis of major depression, anxiety, or post-traumatic stress disorder, which again, all of these are not uncommon in patients with severe epistaxis and HHT, then it's really severe. It doesn't so matter how much what their ESS is, for example, or how much IV iron they need. If they're unemployed because of their nosebleeds, it's severe. We obviously want to do something about it. So whichever domain of these 3 scores the highest is how I define that patient's severity. 2 domains might be mild, 1 severe, the patient is severe. 2 might be moderate, 1 severe, the patient is severe. 1 domain mild, 2 moderate, the patient is moderate. Briefly, the epistaxis severity score is a quick 6-question score. I ask all of my HHT patients at every clinic visit. It's easily calculated at hhtess.com. It's 6 questions. It takes a few moments. It's not a complicated measurement. I finish it in about a minute. It's scored simply. 0 to 1 is minimal epistaxis, 1 to 4 is mild, 4 to 7 is moderate, 7 to 10 is severe. All right, so briefly, we'll talk about systemic antifibrinolytics, which are appropriate for patients with mild to moderate bleeding. There were 2 randomized controlled trials of tranexamic acid to manage epistaxis and HHT that have been completed. One trial of 118 patients found a modest but significant reduction in epistaxis duration of 17%. Another smaller crossover trial found a 54% improvement in an epistaxis composite endpoint that included both duration and severity. Additionally, there have been retrospective patient series describing improvement in GI bleeding with tranexamic acid and epsilon aminocaproic acid. And importantly, none of these studies showed an increase in thromboembolic risk, right? People very commonly approach me with concerns about continuing 4 grams of aminocaproic acid or tranexamic acid daily in HHT patients indefinitely, right? Most of the time we use these drugs as needed, post-operatively, we give for a week, we give for 2 weeks. And for HHT patients, we're giving them indefinitely. So, the randomized controlled trials didn't look at patients beyond, 3 months. And patients in real life are getting them for many, many months or years. There was a small observational study that looked at patients for, a rather substantial length of time, median duration over, mean treatment duration of over a year. Didn't find any VTEs, any increased risk in VTEs. And I have to say, I've treated, well over 100 patients with HHT with chronic antifibrinolytics, and there's no, in my anecdotal experience, no increased risk of venous thromboembolic events. So it does appear safe, but again, the amount of improvement is limited. This is not going to take a patient who is, a red blood cell transfusion dependent and liberate them from red blood cell transfusions in the vast majority of cases. This is appropriate for patients as a first step prior to anti-angiogenic therapy in patients that have more mild to moderate bleeding. All right. Now, briefly, I want to talk about local ablative therapies and surgical management, which previously in the past was the mainstay of bleeding treatment in HHT, but no longer is. It still remains an important treatment modality today. So local ablative therapies that can involve laser, electrical, or chemical cautery, sclerotherapy, embolization, are employed by our colleagues in ENT otolaryngology to eliminate existing telangiectasias in the nose. Again, this is temporizing. It can provide partial improvements in epistaxis with mostly minor side effects. Given our understanding of, again, those underlying signaling pathways, though, we don't want to do tissue damage, which is by definition done when we do these. So we have really moved away from using these for regular maintenance of bleeding. We now only use them when a patient really needs urgent control of bleeding. So there are surgeries that are employed to manage severe recurrent epistaxis. It includes something called a nasal septodermoplasty. It's basically a skin graft from a patient's thigh to their nose, their nasal mucosa. This can be effective when performed by an ENT surgeon with significant experience and expertise in doing the procedure, but complications are very common, okay? That includes bacterial infections, significant malodor from the graft. You can't escape the malodor because it's in your nose and other people around you smell it. There's crusting that happens, nasal airflow obstruction, sloughing off of the graft. Most patients report a decrease in sense of smell and taste because their nasal mucosa is being covered by skin. Nasal closure or Young's procedure can be performed as what we would consider a last resort. This achieves cessation of anterior nosebleeds at the cost of the ability to breathe through the nose and in large part the senses of taste and smell. All right, so this is really something that we avoid in the modern day with newer therapies and clinical trials coming down the pipeline. For GI telangiectasias, plasma argon coagulation can be used, but is not recommended unless the lesion is actively bleeding at the time of endoscopy, okay? So what should never be done is a patient having every single telangiectasia intervened upon at the time of endoscopy just because they're seen. This, again, will just cause the patient to have much worse telangiectasia burden a few months down the line. Systemic bevacizumab, as we all are aware, is a monoclonal IgG1 antibody directed against vascular endothelial growth factor, initially approved 2 decades ago to treat malignancy. It remains the most well-studied anti-angiogenic agent used to treat bleeding in HHT. In HHT, we dose it at 5 milligrams per kilogram as a starting dose, considerably lower than the 10 to 15 milligrams per kilogram doses that are more commonly used to treat patients with cancer who receive it in combination with cytotoxic chemotherapy. In HHT, patients undergo induction with 4 to 6 every other week treatments to achieve hemostasis and induce regression of telangiectasias, followed by maintenance treatment to prevent telangiectasia and bleeding recurrence. Recognize that telangiectasias and bleeding almost universally recur eventually if no maintenance infusions are given. The vast majority of HHT centers in North America, including mine, use continuous maintenance, which most commonly involves giving every 4-week infusions of bevacizumab to prevent rebleeding. Sometimes we start with monthly and we attempt to space them out as much as possible without seeing bleeding recur. I've gotten patients out to every 8 weeks, every 10 weeks, every 12 weeks, rarely beyond that, and many patients can't make it out that far, but some can, and so it can be worth trying to space out the maintenance infusions in many folks. Now, I have here on my slide 3 stars out of 5 for epistaxis and 4 stars out of 5 for gastrointestinal bleeding. And this is reflective of my experience in treating hundreds of patients with anti-angiogenic therapies in HHT. Bevacizumab tends to be best for gastrointestinal bleeding. It certainly can work for epistaxis. It can work nicely, but it is not as good at treating epistaxis, in my experience, as it is in treating gastrointestinal bleeding. This is my go-to gastrointestinal bleeding drug if I don't have a clinical trial available for a patient. This is just an example of an early patient, one of the first patients we treated many years ago, over a decade ago at this point, with systemic bevacizumab. And as you can see, she experienced dramatic improvement in bleeding and anemia. She was liberated from red cell transfusions, as you can see here, and her hemoglobin normalized. And this is a typical response to bevacizumab, and I would see a majority of patients. Now, what this curve doesn't show, what this graph doesn't show, is that this very same patient, after 3 to 4 years of treatment with bevacizumab, it stopped working. And even though we were giving her bevacizumab every 2 weeks, even though we increased the dose of the bevacizumab, her hemoglobin dropped back down to the 7s, her bleeding returned. We don't understand why this happens, but it absolutely does happen in a significant percentage of patients with HHT, probably about half who we treat with bevacizumab who initially have a good response. So bevacizumab can be quite life-changing, but it doesn't appear to be, even with maintenance, durable for the, indefinite durations. Usually it works nicely for a few years, and then we have to switch to something else, and sort of almost an oncology paradigm where we treat for as long as it will work, and then we switch to something else. This is an early case series, again, a swimmer plot. A swimmer plot shows each lane is a patient over time. Each red circle is a red cell transfusion event. Larger circles representing more units of red cells transfused. Each blue diamond is an iron infusion event with the size of the diamond representing the amount of elemental iron given during that event. And as you can see, in the 6 months prior to bevacizumab, there are numerous iron and blood transfusion events. And once bevacizumab induction begins, the events taper off as hemostasis is achieved. Patients are still iron deficient, and some require most require some iron repletion. But as you can see, after that initial repletion, most patients are good. And again, this is for, this shows, 6 months of maintenance, right? So about half of these patients that were on this graph have progressed and now are on different therapies because bevacizumab no longer works for them. This is the hemoglobin response in this same group of patients. As their red cell transfusion and iron infusion requirements went down, their hemoglobin improved. And this is something that is very satisfying for doctor and patient alike because the visible telangiectasias on the patient's face and mouth will often shrink down, involute, go away. It's very pleasing for everyone. Inhibit Bleed was an international 12-center observational study of HHE patients treated with systemic bevacizumab between 2011 and 2019, primary indication of which was treating chronic bleeding and anemia. Bevacizumab was offered for this indication only to HHE patients with moderate to severe bleeding and collected all of the relevant outcomes and safety. This was 238 patients across 4 countries who were treated with bevacizumab for a median of 12 months. Most patients, 181, about 3/4, received maintenance treatment. And, you know, the patients ran the gamut from their 20s of age to 90s. About 2/3 were female. And again, that's not uncommon in HHT studies to see a female predominance because, again, overall manifestations appear to be more severe in women. And these patients, this is a real world population. You know, a lot of patients had hypertension, about 1/3. Patients had CKD, diabetes, prior venous thromboembolism, all things we think about when we're using bevacizumab to treat patients. Hemoglobin improved after initiation of treatment from baseline by an average of about 3 grams. Epistaxis severity score improved substantially. Red cell transfusion requirements improved considerably, as did IV iron infusion requirements. Bevacizumab was overall well tolerated, as shown by this graph that illustrates the bevacizumab-related treatment-emergent adverse events observed over more than 340 patient years of bevacizumab treatment. So, you know, hypertension in about 20%, either new onset or exacerbation of pre-existing hypertension, easily treated with antihypertensives in the vast majority of cases. Some proteinuria, you know, we treat the proteinuria by lowering the dose of the bevacizumab to 2.5 milligrams per kilogram and seeing if that makes it go away. VTE rate was only 2%, okay, which is similar to the background rate in HHT. And, you know, patients did not seem to have a higher adverse event burden if they had been on the drug for longer. And I can say, you know, I have a number of patients that were getting up to a decade or longer of treatment and who still happen to have the drug work for them, right? That's a minority, but we haven't seen any, you know, emergent late toxicity of using bevacizumab for a long period of time. In terms of the toxicity management, I already went through much of this. I will just say that for a patient who develops a venous thromboembolic event while receiving bevacizumab, we treat through because the bevacizumab is controlling their bleeding and we start anticoagulation and the patients almost universally do well. Starting anticoagulation in a patient who has achieved nice durable hemostasis from anti-angiogenic therapy, whether that's bevacizumab or pomalidomide or any other therapeutic that we use, tend to do well with the anticoagulation or antiplatelet therapy. So now just going to switch gears to immunomodulatory IMiD drugs. So thalidomide is our well-known prototypical immunomodulatory IMiD drug, or IMiD, with anti-angiogenic properties used for multiple myeloma primarily. You know, this drug has many different effects, and it does downregulate vascular endothelial growth factor, basic fibroblastic growth factor. In some nice studies, biopsying vessels pre and post in HHT, we see that it improves vessel wall integrity, decreases the leakiness of these vessels. So it does help in treating bleeding. There hasn't been a large, you know, significant study in HHT, but there have been multiple small studies. And most of those studies report improvements in bleeding-related parameters and hemoglobin, epistaxis severity, so on and so forth. But for anybody who's used thalidomide chronically, you know that this is a toxic drug, or certainly can be. Some patients do fine, but some patients develop neuropathy, and that neuropathy is often irreversible. And there is a significant thromboembolic risk with thalidomide use. Pomalidomide, though, as we know, is a newer thalidomide derivative without the neuropathy concerns, with a lower VTE or thromboembolic risk that is believed to have many of the same properties in anti-angiogenesis as thalidomide, and so was selected to be evaluated in a large NIH-funded study called PATH-HHT. So pomalidomide, PATH-HHT was a multi-center U.S. randomized controlled study which planned to enroll 159 patients with HHT and moderate to severe epistaxis, as determined by the epistaxis severity score, and randomize these patients 2-to-1 to receive once daily pomalidomide, starting at a dose of 4 milligrams daily, or matching placebo for 4 weeks. All right. Many people will ask, well, in myeloma, we do 3 weeks on, 1 week off with pomalidomide. What about in HHT? In the PATH-HHT study and in how we treat patients, there's no off week. Patients just receive pomalidomide daily indefinitely, okay? So the intensity of treatment is actually higher in patients with HHT than it is in myeloma. This study was closed to enrollment early when a planned interim analysis achieved pre-specified early stopping criteria for efficacy after 75% of patients had completed the study and a total of 144 patients were enrolled. So really the best possible outcome, stopping early for efficacy. And the primary results of PATH-HHT were presented as a late-breaking abstract at ASH last year. Patients treated with pomalidomide had a statistically significant improvement in ESS compared with placebo, an improvement that was also highly clinically relevant, equal to 2.5 times the MCID for the epistaxis severity score, the minimal clinically important difference. Because the epistaxis severity score is an instrument based on recall, there was initially a strong placebo effect, as you can see here. But then that effect wanes over time as the improvement in the pomalidomide arm intensifies, okay? A similarly clinically relevant improvement was also observed in an HHT-specific health-related quality of life instrument, which again initially showed a strong placebo effect that then waned over time. The most common adverse events with pomalidomide, each occurring in about 30 to 50% of patients, included constipation, diarrhea, multiple or mild to moderate neutropenia, and rash. And really, is when we talk about constipation/diarrhea, we're talking about constipation is really being the main gastrointestinal side effect. Venous thromboembolism was rare and occurred in similar proportions of patients in both pomalidomide and placebo groups, which is very reassuring. So based on the findings of the pivotal PATH-HHT trial and my own experience, again, treating over 50 patients with pomalidomide and many, many more with bevacizumab, I recommend pomalidomide as a treatment option for moderate to severe epistaxis and HHT. I found that bevacizumab, as I mentioned before, tends to be ideal for gastrointestinal bleeding, though it also works for epistaxis, and pomalidomide is the opposite. And I would say this is also true for thalidomide and other immunomodulatory IMI drugs. Pomalidomide tends to be more ideal for epistaxis. I give it 4 stars out of 5 for epistaxis and 2 stars out of 5 for gastrointestinal bleeding. This is, again, generalization. It's not necessarily true in every patient. If one drug doesn't work, the other one can and often should be tried, I will say. Pomalidomide and HHT is dosed daily without off weeks. I start at 4 milligrams daily for most patients, like the PATH-HHT trial. But because of the tolerability issues in patients with older adults and those patients who have pre-existing constipating diseases or bowel diseases, I start at 2 milligrams daily in those populations. And it's pretty simple. You just continue therapy as long as response is maintained. You know, pomalidomide has more toxicity kind of on a general basis than bevacizumab, but the fact that it's oral really provides convenience for patients that they appreciate. You know, with most toxicities, we just reduce the dose by 1 milligram daily and continue. For severe neutropenia, if a patient has an ANC less than 1,000 or even less than 800, I'll hold pomalidomide until the ANC recovers a bit and then restart at 1 milligram lower per day than the previous dose. The neutropenia in these patients is really not clinically relevant. The vast majority of patients. It's rare for a patient to develop neutropenia with an ANC of less than 500. I've never had a patient despite, you know, again, treating many of these folks with this drug for now many years, Never had a patient have febrile neutropenia or neutropenic fever. The rest of their immune system is, very robust, unlike patients with hematologic malignancies. They have eosinophils, they have basophils, they have monocytes, they have otherwise normal immunity. So this is really what I call cosmetic neutropenia. The number is lower, but it doesn't have much of a clinical relevance. Patients can have a rash with pomalidomide, which we certainly also see in patients with myeloma when we start pomalidomide in certain patients. It is usually short-lived, okay? Usually lasts for about 2 weeks. And then it goes away, and we can treat patients through it. There are occasional cases where it's severe or persistent, in which case we have to stop the pomalidomide. And again, with patients who happen to develop thromboembolism on pomalidomide, I think I've had one who has developed a thromboembolism on pomalidomide. We just start anticoagulation and we continue the drug, because if their bleeding is under good control, then they are able to be anticoagulated just fine. All right, now to switch gears a little bit to pazopanib. So pazopanib is a vascular endothelial growth factor receptor blocking tyrosine kinase inhibitor, currently approved to manage solid tumor malignancies like renal cell carcinoma and GIST and other soft tissue sarcomas. In a 7-patient proof of concept study in which patients with HHT and bleeding were treated with really low doses of pazopanib, 50 milligrams daily, as opposed to the starting dose of 800 milligrams daily in patients with cancers. Most of those patients had a significant improvement in their epistaxis and also in GI bleeding, and the drug was well tolerated at a low dose. So this led to a bit of off-label use of pazopanib, and that's what I have here on this slide. This is an observational retrospective analysis of 13 patients treated with pazopanib who had the worst HHT. They had a red cell transfusion-dependent disease, as you can tell from the swimmer plot. Most of them had previously failed bevacizumab, and they were started on low-dose oral pazopanib. And most patients, the pazopanib was up-titrated by 50 to 100 milligrams per titration, up to 400 milligrams daily. So even the highest dose was half the dose used in cancer, half the starting dose in cancer. Most of these patients prior to starting pazopanib were being referred to hospice because they were just bleeding so profoundly and didn't have other treatment options. So, it's very easy to see here what happens after pazopanib was started. Most of the patients achieved red cell transfusion independence, many needed intermittent IV iron, but otherwise did very well. And so, again, pazopanib is a promising agent that is currently in clinical trial, right now. Again, a US government-funded clinical trial of pazopanib at 12 centers in the United States is currently ongoing. But again, this drug it's not a new drug, and it's widely available for cancer. And if the patient can afford it and buying it off label, it is an option to use in patients with HHT. The cancer dosing at 800 milligrams daily. The pills are 200 milligram tablets. So, you can start a patient on 200 milligrams every other day, and that achieves dosing intensity of 100 milligrams daily, and see how it improves their bleeding. Monitor ECG, monitor thyroid studies, just like with patients with cancer getting pazopanib. But this drug can be quite helpful. So, every drug I've talked about up until now has been associated with, has been a repurposed drug, right? These are cancer drugs that we're repurposing to treat HHT because of anti-angiogenic properties. Well, I'm very happy to report that the very first industry-funded, industry-developed drug, a drug that was designed specifically to achieve an optimal balance of efficacy and toxicity in HHT, not developed for cancer and then adopted for HHT. This drug is called VAD044, and it's an inhibitor of AKT, an allosteric inhibitor of AKT. And the PI3 kinase AKT pathway is one of the downstream pathways from the transforming growth factor beta ALK1 pathway that we see is lesioned in HHT. And it's upregulated. This pathway is upregulated in patients with HHT. So and it's important in vasculogenesis and angiogenesis in production of pro-angiogenic growth factors. So by inhibiting AKT, we can reduce HHT disease activity. And all that is publicly available right now is a press release. The trial was positive, and I was an investigator for this trial, one of the co-lead investigators. The primary endpoint of the trial was safety, and VAD044 was similar to placebo for off-target adverse events. And on-target adverse events associated with AKT pathway inhibition were mostly mild, transient, and resolved without discontinuation of study drug. And at 12 weeks of treatment, patients receiving the 40 milligram dose had really clinically meaningful reductions in numerous epistaxis endpoints. And this continued into the open label extension where improvements continued. So this is a once daily pill. It's a very promising agent in terms of a novel agent to treat HHT. And we hope to see additional later stage trials coming soon. I frequently get asked about hormonal agents to treat bleeding in HHT. So, we recognize, of course, that high-dose estrogen can be a potent hemostatic drug in the hemorrhaging patient, whether they have HHT or not. HHT patients bleed chronically, so chronic treatment at more moderate doses would be used in HHT. There was a very old clinical trial, now about 40 plus years old, a randomized trial that looked at oral estrogen versus placebo in HHT, finding no significant benefit for the oral estrogen treatment. And since then, there's been a modest body of literature describing the potential benefit of selective estrogen response modifiers, or SERMs. And this category includes drugs like tamoxifen, raloxifene, bazodoxifene. And the benefit documented has been quite variable between studies. And I think that I'm sure that some patients do experience benefit in their bleeding, but the thrombosis risk is quite real. This is not a theoretical risk like with tranexamic acid, for example, or even with anti-angiogenic drugs. This is a very real risk. And with some of these drugs, there's an increased risk of, endometrial cancer over time. Oftentimes these drugs can provoke, really unwanted adverse events and side effects on constitution and fatigue and things like that. So for all of these reasons, they are not recommended for use in the second international HHT guidelines to treat bleeding. Doxycycline there was a lot of excitement around the potential for doxycycline in HHT in the last few years, because doxycycline it's an antibiotic, yes, but it's a matrix metalloproteinase inhibitor. And so it may have anti-angiogenic properties. And so there have now been 2 randomized controlled trials that were unambiguously negative. Primary endpoints in both studies negative. Every secondary endpoint in the major study was negative. There really is, it's very clear that this drug is not efficacious in treating HHT bleeding, at least on a population level. Is it possible that some patients with HHT have worsened bleeding because of bacterial colonization in their nose, increased inflammation in their nose, or even potentially in the GI tract, and that giving them an antibiotic to reduce that inflammation might be helpful, at least for some length of time? I do think that's possible, but I do not treat patients with doxycycline specifically to treat bleeding, and I recommend against it. So and this is a talk on bleeding in HHT and advanced therapies in HHT, which are predominantly to target bleeding, but I'll just briefly mention on visceral AVM management and the recommended screening for visceral AVMs as put forth in the second international guidelines to treat HHT are as follows. At the time of diagnosis, all patients should have a transthoracic echocardiogram with agitated saline contrast. also known as an echo bubble study, to screen for pulmonary AVMs, and if positive, should proceed to chest CT with contrast for confirmation and characterization of pulmonary AVMs. These can continue to grow over the course of life, so patients with a negative bubble study should have it repeated approximately every 5 years. All patients undergo a brain MRI, or it's recommended that they undergo a brain MRI to screen for brain AVMs after they are diagnosed with the disease. Brain AVMs and HHT are usually, but not always, congenital, meaning that for the vast majority of patients, if the screening MRI that you get one time is negative, you're likely in the clear. Now, we know that this is not true for everybody. Some patients can develop brain AVMs over the course of life, but MRIs are expensive, not always available. So, generally speaking, I only repeat MRIs in patients who have concerning neurologic symptoms that are new or different, and in patients that have a very strong family history of brain AVMs in their family's HHT. And you only need to repeat MRIs every decade or so if you're going to do it. Liver AVMs are identified with Doppler ultrasound of the liver or liver MRI, and offering screening Dopplers is recommended in the HHT guidelines. There is some controversy here because some people point out, well, if the patient is asymptomatic, what am I going to do about those liver AVMs that I find in imaging? There is a contingent of folks, myself among them, that believes that because bevacizumab and potentially other anti-angiogenic agents may be effective at reducing the progression and potentially shrinking liver AVMs that are small and when they're discovered early, that there may be a role for using these drugs. Now, I would only do this in a patient if they had asymptomatic liver AVMs, if their echocardiogram, for example, showed increased cardiac output, cardiac index, and if their right heart catheterization showed that their cardiac output was significantly increased. They have so-called a high cardiac output state. Then there might be some consideration of, should we start bevacizumab to try to prevent the patient from developing high output heart failure? Because many of those patients with a high output state ultimately develop high output failure. Visceral AVMs, I hope I'll be speaking to you in a few years, telling you about how some of these therapies like VAD044 and potentially others in the pipeline are effective for treating not only bleeding, but clearly effective for treating visceral AVMs. Right now, our mainstay of therapy for visceral AVMs remains procedural. Pulmonary AVMs should always be intervened upon if large enough, and if our interventional radiology colleagues can intervene on them. Standard management is embolization. Brain AVMs, it's a case-by-case basis. I refer my patients to neurology or neurosurgery to evaluate the brain AVM and determine if it is safe for intervention and what intervention is best. And liver AVMs, as I mentioned, we do use some systemic therapies now, including bevacizumab. These are not cured with therapies. They can hold off progression for a period of time, but ultimately the patients usually require a transplant if we're able to get it. More of my patients with HHE liver disease die of their liver disease than are able to get a transplant. We do not do hepatic artery embolization. It's unsafe. There's a morbidity of 10 to 15%, or excuse me, mortality of 10 to 15%. So just for some additional resources as I finish my talk here, Second International HHT guidelines are available on Annals of Internal Medicine website for it's open access, free access, and also on hhtguidelines.org as for free for everyone. I published a guidelines highlights for the hematologist in blood a few years ago after the guidelines just came out, which includes many of the things I talked about today, but additional things including management of anticoagulation, antiplatelet therapy in patients with HHT, and then actually just published a How I Treat Bleeding in HHT article in Blood just recently, a couple months ago, came online. So This includes the modern updated data for pomalidomide use and guides through several case-based scenarios on how I treat bleeding in these patients. So in conclusion, HHT, autosomal dominant, not that rare. It's second most common hereditary bleeding disorder with significant morbidity and no approved therapies yet. Hopefully soon. Anyone can diagnose HHT very quickly in the office using the Curacao criteria. I didn't talk about this specifically in this talk, but you don't need imaging to diagnose it in most patients. You have a family history, telangiectasia on the skin, and recurrent nosebleeds, and you've made the diagnosis. For every man with hemophilia, there is a woman and a man with HHT, and HHT appears to be the most morbid and clinically significant inherited bleeding disorder of women. Recurrent and often severe epistaxis is near universal. GI bleeding and iron deficiency anemia are very common, as are AVMs and organs. Most patients have at least one or more organs involved with AVMs. Monitor for iron deficiency, treated aggressively in HHT. Don't hesitate to give IV iron. Avoid ferric carboxymaltose because of treatment-emergent hypophosphatemia. If you can, avoid iron sucrose and ferric gluconate just because of how slowly you have to give those drugs and how little iron you can give with each infusion. That's optimal as well. Systemic therapies to reduce bleeding and telangiectasias, particular anti-angiogenic treatments, are now standard of care. Intravenous bevacizumab and oral pomalidomide are highly effective and safe to manage bleeding in HHT. Other promising systemic therapies like VAD044 and pazopanib are currently in development to treat HHT. So with that, I'm very happy to take questions.
Thank you, sir, for that fantastic talk. That was lovely, and we learned so many new things today from you, sir.
My pleasure.
Great. Thanks a lot. I request all our discussants to please put the raise hand sign so that we can start our question answer session. Dr. Agarwal, sir, your question, please.
First of all, thank you so much for accepting our invitation, giving this wonderful talk. I don't have a question, but after reading your publications, I have a family of about 40 patients of HHT, and many of them have the changed life with bevacizumab and thalidomide, and 50% to more reduction in their bleeding, iron requirement, transfusions, etc. So thank you very much for this research and the education. Thank you.
My pleasure. That's wonderful. I love to hear it. It's always the highlight of my day when a patient that just started on bevacizumab or thalidomide or pomalidomide comes into clinic and they're so happy that they're not bleeding as much, and it's just so their life is so different. So I'm very happy to hear whenever anyone has success.
Just one question.
Yeah.
Should we switch over thalidomide to pomalidomide?
If you have, if pomalidomide is, in the United States, pomalidomide is very, very expensive. So sometimes people are not able to access it, and thalidomide has to be used because of cost issues. But if you're able to get access to pomalidomide, I would. I would, because pomalidomide, the risk of neuropathy is close to zero. But with thalidomide, it's quite significant. If someone's been on thalidomide for many years and has not developed neuropathy, it's probably fine to leave them on it. But if they're more early on in the course of treatment and they're still at risk within the first 1, 2, 3 years of treatment, I would probably try to switch them over to pomalidomide.
So we have pomalidomide generic, so cost is not an issue.
That's great. It's very hard to get here. So we have to, beg the drug company and get, a free supply of drug from the drug company, because 1 year's supply of pomalidomide in the United States is $370,000. It's completely ridiculous. So yes, I think that's great that you have it available, and I would use it preferentially at this point based on the results of the PATH HHT study.
Thank you. Thank you.
Mm-hmm.
Thank you, sir. Dr. Archit, your question, please.
Thank you for the wonderful talk, sir. Given the risk of bleeding in these patients, how to optimize these patients pre-operatively if they need any surgical procedure, endoscopy, or even cauterization?
Great question. So if a patient is going to surgery for, or going to the OR for an endoscopy, for cauterization, nasal procedures, so on and so forth, I always will give them a dose of prophylactic antibiotics. Amoxicillin 2,000 milligrams single dose is my go-to. If someone has a penicillin allergy, you can use something else like clindamycin. Single dose is adequate, just because, again, with AVMs, they're at risk of developing deep-seated tissue infections. We just see very unfortunate cases of people with brain abscesses or, hip abscess or epidural abscess, post-dental work or post a procedure, any kind of surgery. Generally speaking, we advise, if possible, to use IVs with filters because of the risk of air embolization across an AVM, which can cause a stroke. So, if the filters are available, which sometimes they are, sometimes they aren't, we say use them. If they are not available, it's okay. But the nurse should be very careful to try to avoid air in the line. If a patient has severe bleeding and they need a major procedure, like, for example, let's say they have very, very severe epistaxis and they need a major orthopedic surgery or cardiopulmonary surgery, and they need to go on anticoagulation. That is a good time for a local ablative procedure. You have a time-limited period where they need to be on a blood thinner, and you don't want their epistaxis or their gastrointestinal bleeding to get much worse. So it's reasonable to prepare them for surgery by doing a local ablative procedure to get them ready. But if somebody needs long-term anticoagulation, and they have at least moderate bleeding, I will actually start them on bevacizumab or pomalidomide, some anti-angiogenic drug, to control their bleeding, recognizing that with the blood thinner, it's likely to get worse. About half of patients cannot tolerate anticoagulation or antiplatelet therapy. That includes a daily baby aspirin. It can be very, very challenging for these patients. So I don't hesitate, because we know that these treatments are safe and effective. It improves the patient's quality of life anyway, and it allows them to be properly anticoagulated.
Thank you so much.
Absolutely.
Thank you, Dr. Arjit. Dr. Satish Kumar, your question, please.
Thank you so much. Many eye-opening concepts. You've answered one question on anticoagulation and antiplatelet therapy in HHT, which can be quite challenging. The other question I had was for the confirmation of the diagnosis, do you do a genetic testing in your patients, and do you advise prenatal testing in expectant mothers?
That's an excellent question. So genetic testing, if the patient is able, if they're in the United States, we have health insurance, and if the insurance covers it, I get it. If the insurance doesn't cover it, it can be challenging sometimes because it's a lot of money out of pocket. Technically speaking, you don't need genetic testing to confirm the diagnosis. If the patient meets 3 or 4 out of the 4 Curacao criteria, you have your diagnosis. It's definite. But I do try to get the genetic testing because it can be helpful, right? If you know the mutation in that person, you can check other family members for the mutation. And if they have an endoglin mutation, they're at higher risk for brain AVMs, lung AVMs, and spinal AVMs. If they have an ALK1 or ACVR1 mutation, they're at higher risk for gastrointestinal AVMs and liver AVMs. Now, there's a lot of overlap, right? Any type of patient can develop AVMs anywhere, but those tend to be, greater propensities. And there is the small subset I didn't talk about in my talk of SMAD4 mutated HHT, which is juvenile polyposis HHT syndrome, which those patients are very high risk of colorectal cancer and other GI cancers. And it's very important to identify them and do proper screening for their cancers, regular screening for their cancers. I've seen sad cases of people dying in teenage years of metastatic colon cancer because it just wasn't identified that they had a SMAD4 mutation. Second question is for expectant mothers, and the answer is yes. I think that it is as much as possible, it is good to know if a baby is going to have HHT. If there are concerns or risks about doing it while the woman is pregnant, it can be deferred until after the baby is born. But obviously, at that time the baby is born, and doing MRIs and things like this in a baby can be challenging if you're trying to diagnose. So I do like to do genetic testing prior to conception, and as much as possible, if possible, an egg without the mutation can be implanted.
So pre-implantation embryo testing, right?
Yes.
The second question was regarding iron infusion. We use ferric carboxymaltase left and right. I mean, that's the commonest preparation, unfortunately. So what is the
Same
incidence
here,
of...
same in the United States, most common. I don't use it, but it's most common.
Right. And I mean, I'm not talking about just HHT population. What is the incidence of symptomatic It's quite scary to see those slides on hypophosphatemia, but what is the incidence in your practice? And does it happen with the other preparation? We have iron isomaltoside.
Yeah, iron isomaltoside is great. Iron isomaltoside does not cause treatment-emergent hypophosphatemia, except in very rare cases. The rate is like less than 4%. With ferric carboxymaltose, the rate of hypophosphatemia is 50 to 75%. So most patients will get it. What is the rate of symptomatic hypophosphatemia? Probably around 20 to 30% of the time is it symptomatic.
That's
right? But you're treating patients with iron deficiency, so they're already symptomatic. So you make them feel better from the iron deficiency standpoint, but like I showed in my slides, they don't feel as good as patients who get a different IV iron formulation, and that's directly tied to the phosphate. I mean, it's something. I don't want to monitor phosphate levels, after I give IV iron, and moreover, like I said, there's not much you can do. You can give oral phosphate. They just pee it out a few hours later. You can give IV phosphate. They just urinate it out a few hours later. There's not much you can do. And if patients require repeat infusions like inflammatory bowel disease and HHT and other chronic bleeding problems, then you really are at risk for the osteomalacia and all of the complications there. Right. So use iron isomaltoside, use ferromoxitol if you have that one. Low molecular weight iron dextran, those are my go-tos. I really try to avoid ferric carboxymaltose.
Thank you so much. Thank you.
Yep.
Thank you, Dr. Satish. Dr. Cecil Rose, your question, please. Dr. Cecil Rose. Okay.
Dr. Ross?
Anyways, Dr. Mukul Agarwal, your question, please.
Hi, thank you, Dr. Hani. Couple of questions from my side. So, with pomalidomide and thalidomide, it is one of the routines to give antiplatelets. So, do you advise for these patients also? And
That's a great
secondly,
question.
After the initial dosing for, let's say, few months, do you recommend decreasing the dose of both these drugs to decrease side effects for like a maintenance longest time?
That's a great question. So the first question is antiplatelet therapy with either thalidomide or pomalidomide in HHT. The short answer is no. And all of the clinical trials, there was a small clinical trial of thalidomide, and this large PATH-HHT study did not use antiplatelet prophylaxis to try to prevent VTE. As I mentioned, you can have increased bleeding even with a baby aspirin in HHT, so we did avoid it. There was no increased risk for VTE as far as we can tell, and I've treated many patients now for many years, and I've not seen an increased risk. So it turns out that, and this is true with bevacizumab too, right? With bevacizumab in patients with colorectal cancer, a VTE rate of 10 to 15%, but in HHT it's 2%. The patient population, the underlying risk, increased risk of venous thromboembolism and cancer really does seem to interact much more with these drugs, both thalidomide, pomalidomide, and bevacizumab, than the underlying state of HHT. So as far as we can tell, these drugs do not appear to be significant increased risk for thromboembolism. So I do not use aspirin. And then, I'm sorry, can you repeat your second question, Dr. Agarwal?
The maintenance dose, do you decrease the
Maintenance
dose
dose.
after?
Yes, maintenance dose. It's a good question. With bevacizumab, as I mentioned, I'll space it out in many cases. With thalidomide and pomalidomide, not as much. If the patient is tolerating the drug well, that doesn't mean it's wrong. We just don't have the data. So no one has tried, reducing the overall treatment intensity after a person, let's say they're on it for 6 months or 12 months, they have good control of their bleeding. No one has really tried, and that includes me. I've largely continued patients on the same dose. Now, what I will say is, when I've had to reduce it for toxicity, usually patients do just fine. So 4 milligrams daily is empiric. That there's no strong evidence to say that you need 4 milligrams daily. Maybe 3 milligrams or 2 milligrams daily would be just as good overall, but no one has tested it. So it remains an open question. I guess I would say I wouldn't hesitate to decrease the dose if they have toxicity, and I wouldn't hesitate to decrease the dose even if you just want to try. The worst that happens is their bleeding gets worse and you can go back to the prior elevated dose.
And have you used tranexamic acid with these two agents and found any problems?
I have, and I do. Not that infrequently in my most severe patients. And I have not seen an increased risk of venous thromboembolic events in the patients receiving both tranexamic acid and anti-angiogenic therapy. In fact, it's something that I will often do in patients who have very severe bleeding, because sometimes it takes time for the anti-angiogenic drug to start working. You can take up to a month, for the effect to start for both bevacizumab and pomalidomide and thalidomide. And for that reason, I will often start them on tranexamic acid just as a bridge to the other drug starting to work. And then when the other drug starts to work, I taper off the tranexamic acid. But in patients that have very severe bleeding, I keep them on both indefinitely, and they tolerate it well.
And just lastly, why lenalidomide was missed out?
So that's a great question. So the decision was made to proceed with pomalidomide because of the belief that toxicity would be the least between all of the agents that were available at the time, which was thalidomide, lenalidomide, and pomalidomide. Now, lenalidomide, one thing that we have not discussed in greater detail here is the risk of secondary malignancies with these drugs, with IMiDs. And there actually was a very nice study done by Dr. Adam Sperling that was published in Blood a couple years ago, showing that lenalidomide increases the risk for secondary malignancies by promoting the selection of p53 mutant clones. Pomalidomide in his study did not do that. So there are differences in these drugs between that risk. And with HHT, right, I have patients in their 30s and their 20s that are on these drugs. They're doing very well, that do not want to come off. They have many decades of life to live. So I would want to use the drug that is least likely to potentially increase a leukemia risk or a secondary malignancy risk. And so pomalidomide appears to be the optimal agent in that respect.
Thank you. Any other question, Dr. Mukul Agarwal? Fine. Dr. Akanksha, your question, please.
Yeah, hello. So thank you for the very informative talk. So this is regarding a patient a few years back. She was diagnosed with the HHT and she was basically referred to us for pancytopenia. And incidentally, the marrow was hypoplastic. So I just wanted to know whether you've come across any similar cases of hypoplastic anemia with an underlying HHT. And second question is regarding, if a female comes with HHT and regarding the pregnancy management in these cases.
Yeah, that's an excellent question. Both excellent questions. So the first question about hypoplastic or aplastic anemia and any relation with HHT, I have not had I take care of over 500 patients, 500 families with HHT. I've not had any such patient. So I think that is just a case of, a patient developing aplastic anemia who also happens to have HHT. I suspect there's no relation between the two. It's obviously very unfortunate and very challenging because thrombocytopenia and anemia from the hypoplastic anemia is going to make things very challenging with the HHT. I have had patients with HHT who have needed bone marrow transplants because of mantle cell lymphoma and other hematologic malignancies. And getting them through the initial transplant period can be very tough because of the severe thrombocytopenia. I don't hesitate to use lots of antifibrinolytic agents in those patients to get them through that period. And your second question, pregnancy management in HHT is very, very important. So if it's possible before a patient is pregnant to optimize them, that is critical. Optimize iron status. Iron deficiency, in pregnant patients with HHT is near universal if they're not optimized in advance and taken very close care of during pregnancy. And we now know that the iron deficiency in pregnancy increases risk of neurologic problems in the baby, of autism, potentially lowered IQ. We really want to make sure that that's well taken care of. The second thing is that the pulmonary AVMs in women with HHT can grow dramatically during pregnancy. They can grow very fast. And in fact, the risk of pulmonary AVM rupture and fatal hemoptysis, fatal pulmonary bleeding, is about 1% per pregnancy in women with HHT. And so, 1%, it's not that high, but it's per pregnancy, and lots of women have HHT. So if it's possible to screen for pulmonary AVMs prior to pregnancy and intervene on any intervenable pulmonary AVMs, that is optimal. Third, people will get very anxious sometimes about spinal AVMs when giving the epidural. Spinal AVMs tend to be in the cervical and thoracic spine when they happen. It's very unusual for them to be low down where the epidural is performed in the lumbar spine. And so we actually do not recommend MRIs before epidurals to see if there are spinal AVMs present when the epidural is given. We just say to the anesthesiologist, give the epidural. And that's a safe approach, but that question comes up a lot. Beyond that, treatment of bleeding and management of bleeding in pregnancy is tough, right? We can't use any anti-angiogenic drugs. I tend to, in patients who are pregnant, I tend to be very aggressive with the iron. I tend to be more aggressive with local treatments. We can use local tranexamic acid soaked gauze, insert into the nose, things like this. It's rare for a pregnant patient to have gastrointestinal bleeding because usually they're very young. And gastrointestinal bleeding tends to be worse in the 40s, 50s, 60s, 70s. But if it is present, the patient can have some procedures to try to manage it. But most of the time, we just are able to get away with very intensive IV iron and these other preventive managements.
Sure. Thank you. Thank you so much.
Yeah.
Thank you, Dr. Ansha. Otherwise, sir, your question.
We have a hemostatic agent, ethymesalate, which we use. Any experience?
No, I'm not. I don't have experience with that agent. Tell me again what it's called.
Ethymesalate.
Ethymesalate. No, we don't use it. What's the mechanism?
It's supposed to work at the capillary level and produce some kind of adherence between the platelets and endothelium.
Okay. Yeah. No. And you use that for nosebleeds?
We use it for everything.
I mean, is this an HHT in general or in pregnant patients with HHT? Sorry.
No, it's in general.
In general.
So tranexamic acid and ethymesalate are used together to prevent bleeding outside HHT and so many other conditions, including hemophilia, thrombocytopenia, all patients.
I would be very interested to learn more about it. We don't have it available in the United States.
There are publications on it. It's there in the Google and right.
Thank you. I will be sure to read about it. But I mean, again, if it doesn't have a thromboembolic risk and it works well for mucosal bleeding, then that's certainly something that can be used for symptomatic bleeding management.
Right. Thank you.
Dr. Anand Kumar. Thank you, sir. Dr. Anand Kumar, your question, please.
Excellent talk. I understand that there's a risk of venous thromboembolism with the drugs that we are using. So does the disease per se, like I understand the pulmonary AVMs can predispose to venous thromboembolism. And are there any other risk factors and how do you manage? Is there any specific anticoagulant that is prescribed according to the HST guidelines?
It's a great question. So patients with HHT have an increased thromboembolism risk, increased risk of venous thromboembolism at baseline, thought to be mostly related to a number of factors. Number one, chronic iron deficiency increases the risk, causes thrombocytosis, that increases the risk, but even if without thrombocytosis, it increases the risk. Number two, patients with HHT tend to have elevated levels of factor VIII, which increase the risk of thromboembolism, and that's nothing you can do about that. And then thirdly, I mean, it's a vascular malformation disorder, right? So the anatomy, it's primarily microvascular, right? That's abnormal, but patients with HHT can have macrovascular problems as well. They can develop aneurysms. You know, it's not that uncommon to see aortic aneurysms in patients with HHT, mesenteric artery aneurysms, things like this. So there is some macrovascular, problems in normal blood vessels as well. And that may increase the risk due to anatomic abnormalities. There is no specific, we actually did a study looking at this. If you look at the HHT guidelines, they recommend using warfarin and heparin agents preferentially over DOACs. Those guidelines were published in 2020. Since then, we have done a large study looking at all rivaroxaban, apixaban, warfarin, heparin-based anticoagulation, antiplatelet agents. We don't see a difference. Honestly, in about half of patients, you're going to run into trouble. And it's hard to know. Some patients with significant bleeding, you can actually put them on anticoagulation and they do okay. And it's hard to know before starting the patient. But about half the time they do very poorly. And apixaban, rivaroxaban, it's not worse than warfarin or heparin. So there isn't any special drug that tends to work better. It's really more a matter of being vigilant, warning the patient things may get worse, keeping a close eye on their hemoglobin because it drops, in many patients after you start it. Aggressive IV iron management, and if necessary, use of antifibrinolytic and anti-angiogenic drugs. And some people say, you would give an anticoagulation with tranexamic acid, and I say yes, because it works. And patients' venous thromboembolism or AFib is properly treated, and their bleeding improves despite getting the worsened bleeding from the anticoagulant is mitigated by the antifibrinolytic drug.
My second question is, if I understand properly, the AVMs are not treated with the therapeutic drugs that we give, right?
Except for liver AVMs, which sometimes will respond. And it depends on the size of the AVMs. If your patient has many tiny, small liver AVMs, they're much more amenable to treatment with bevacizumab or potentially some of these other drugs. There's less data for the other drugs, which is why we favor bevacizumab for that circumstance. If they have a large liver AVM, 6 centimeters, 5 centimeters of macro AVM, the drugs are very unlikely to do much to help. For lung AVMs, we don't have very much data. We don't expect, based on the cases that I have seen, I have not really seen substantial improvement in the lung AVMs with bevacizumab. But again, and that includes patients who have more diffuse lung AVMs, tiny diffuse ones rather than large ones. Most patients have large ones in the lungs. They don't have many tiny diffuse ones. In the liver, it's very common to have many, many small diffuse ones. And we don't use them to treat brain AVMs, so we don't know.
So for some hypothetical reasons or some rare situation, if the patient is not able to tolerate IV iron, how do you manage other than the blood transfusions?
Ooh. If you have this is a patient that has like multiple allergies and keeps having anaphylaxis, even or infusion reactions, even if you give pre-medication with steroids and antihistamines and everything, still don't tolerate it, I mean, in that case, I will optimize my oral iron management as best I can, recognizing that it's limited how much they're going to absorb. I try to use products that tend to be more well tolerated, like iron polysaccharide complex is one that we use that's better tolerated than things like ferrous sulfate and ferrous gluconate in most patients. And I will do my best to treat bleeding to minimize the blood loss.
Thank you very much.
Yep.
Thank you, Dr. Anand Kumar. So there are some couple of questions from the audience, 2-3 questions.
Absolutely.
If the time permits, can I ask, sir? Yeah. There is a question from Christopher, Dr. Christopher. He has asked about lenalidomide in HHT, you already answered. Another question is, are there cases of HHT which are not autosomal dominant?
So this is really interesting. So it's extraordinarily rare, but there are such. So I will say, HHT by and large is autosomal dominant. Okay, very, very, very clearly, you can have a hypomorphic allele in ACVRL1 or endoglin that causes minimal to no disease in the heterozygous state. That in the setting of consanguinity, you can have a homozygous, a patient who's homozygous for such hypomorphic allele. Now, to be very clear, normally homozygous mutations are embryonic lethal. You can't, it's not compatible with life to have two severe ACVRL1, SMAD4, or endoglin mutations. But there are, I've seen a family that has this described. And the patients who have one copy of the mutation, which is a mild mutation, they tend to have little to no symptoms. They may have an AVM in one organ, they may have some mild epistaxis. And then there are a couple of members of the family that are homozygous for the mutation. They're alive, and in the teenage years, they develop horrible bleeding in AVMs, just awful, like very, very severe. Like they're going to need lung transplants in order to live here in a few years. We're talking oxygen saturation of 60% on room air, walking around with this because it's so chronic and they're used to it. So this would be considered like almost an autosomal recessive sort of situation. But this is extremely rare. The vast majority are autosomal dominant.
Thank you, sir. Another question from Dr. S.K. Sharma. Do we require to go for complete GI endoscopy or capsule endoscopy thoroughly with every cases of HHT initially at the time of diagnosis?
That's a great question. The answer is no. So, number one, you may see the telangiectasias. They develop in 75% of people, but they may not be bleeding, or they may not be bleeding appreciably at the time. And like I said, there's no role for cauterizing or intervening on telangiectasias that are not actively bleeding at the time of endoscopy. So it's just procedures, and it's really just for academic knowledge. Do you have the telangiectasias or do you not? About half of the patients who have telangiectasias in their gut do not ever develop clinically significant GI bleeding. So really, the way when we choose to look for these telangiectasias is when the patient has anemia out of proportion to the severity of their nosebleeds. The patient has an epistaxis severity score of 3, they have mild nosebleeds, but they're showing up with a hemoglobin of 8. That doesn't make sense. There's something else wrong, and that person probably has occult GI bleeding. That's the circumstance where we will start with the upper endoscopy and the colonoscopy, and if we don't see anything, we'll do a video capsule endoscopy or enteroscopy to look in the small bowel. And look, it's less about intervening on the specific bleeding lesion, because at the time of the endoscopy, 2 or 3 of the telangiectasias might be bleeding, but then the next day, different telangiectasias are bleeding. It's not specifically in a patient who has chronic low-grade bleeding. It's not about the intervention. It's about knowing that they're there and knowing that the patient doesn't have ulcers in their stomach, So you can treat them with bevacizumab, right? We don't want to treat patients with bevacizumab who have ulcers causing bleeding. We want to treat patients who have telangiectasias causing bleeding.
True, sir. Thank you, sir. Agarwal, sir, your question?
Yeah. Some of our patients have now become beyond 70. They've had either myocardial infarction or strokes. In such patients, how comfortable are you in continuing all these agents?
Yeah, it's a good question. It's a patient, I do it on a patient by patient basis, risk benefit analysis. But as a general statement, we have treated patients into their 90s with bevacizumab. I find that older adults tend to have more trouble tolerating pomalidomide and thalidomide because of side effect burden. They can get very fatigued. They're more susceptible to constipation. They're more likely to develop severe neutropenia. So I tend to be a little bit more hesitant to use such agents in older adults. If I do use it, I'll start at lower dose. But as a general statement, if someone has severe bleeding, I will, even if they have a cardiovascular history, I'll discuss the risks, but most of the time we proceed with treatment and the patient does fine.
Okay. Thank you.
Mm-hmm.
Thank you, sir. One more question from Dr. Cecil Rose. In a patient who comes to you with recurrent iron deficiency and ogidoscopy or colonoscopy is absolutely normal, and there is no clinical evidence of HHT, is it worth to do NGS in such cases? And what is the pickup rate of NGS in HHT? Or are there any other biomarkers to prove that this can be HHT?
That's an excellent question. So, just to be clear, the patient has gastrointestinal bleeding, but you don't see telangiectasias. Is that what I'm hearing?
Yes.
Okay.
No GI bleed, only recurrent iron deficiency. Upper
Yeah.
GI,
Only recurrent GI bleeding. Only recurrent iron deficiency.
yes.
If they're not bleeding, if they're not bleeding, if you don't have epistaxis, recurrent epistaxis, you go back to the Curacao criteria. You don't have recurrent epistaxis, you don't have telangiectasias on the fingers, lips, typical locations, I would probably not do NGS on those patients. There are a subset of patients who, when we do standard genetic panels for HHT that just look at 5 genes, we don't see anything, and the patient has clear manifestations of HHT. They have telangiectasias, they have nosebleeds, they have AVMs. Those patients have HHT, even though they have negative genetic testing. That's 5 to 10% of patients. It's actually a relatively large percentage. If a patient has recurrent iron deficiency anemia, but does not appear to have any of the other sequelae or stigmata of HHT, manifestations of HHT, I would be worried about iron refractory iron deficient anemia or some of these other rare causes of iron deficiency, possibly some absorptive defect, something like that, occult celiac disease. I would not think that they have. I would not be doing NGS, to try to find, occult HHT, so to speak.
Thank you, sir. And another question from Dr. Mukul Agarwal. Any organ-specific variation in response to drugs, like for GI bleed or urinary bleed or menstrual bleed?
Yeah, so I have found that bevacizumab tends to be better for gastrointestinal bleeding than thalidomide and pomalidomide. And I found that thalidomide and pomalidomide tend to be better than bevacizumab for nosebleeds, okay, for epistaxis. Now, that is, it's not universal. There are some patients that one drug will work really well for, bevacizumab worked really well for epistaxis, for example. I have a patient where the pomalidomide has worked very well for GI bleeding. So it's patient dependent, but as a general statement, that's what I have found.
Thank you, sir. Agarwal, your question.
Yeah, one more question, sir. I have a girl about 12-year-old who has HHT. She has cutaneous telangiectasias and she bleeds from them.
Mm-hmm.
I had not seen this before. Does that happen?
Yeah, that's a great question. Yes. Cutaneous telangiectasias can bleed, oral telangiectasias can bleed. And they're high flow vascular lesions. So they can squirt blood, they can bleed for hours before they stop. It can be very challenging. So if someone just has cutaneous lesions or oral lesions that are bleeding, I don't usually give them an anti-angiogenic drug. I will send them to dermatology for laser therapy on the face or the hands if they have cutaneous lesions. They can also do it on the lips. If it's all oral cavity, I usually send them to a oral maxillofacial specialist or maxillofacial surgeon. So there are some local procedures that can be done on these, and they can be effective. Now, you might say, well, wait, won't that provoke more telangiectasias down the road? It could. But that's currently the standard of care for management of these lesions.
Thank you.
Thank you, sir. Sir, I've finished all the questions from the audience, and there are no more questions in the chat box. Any discussant want to ask any other question? Well, so I think, sir, there are no more raised signs. Well, sir, thank you so much for that fantastic and lovely talk and a very long Q&A session. Your talk
It's
was
really my pleasure.
Fantastic, and so much of knowledge learning we got this time. I think from the next day, if I get any other patient of HHT, that would be very beneficial to me, and I think for all others. Thank you so much once again for that fantastic, lovely talk and wonderful discussion. Thanks a lot.
Mr.
Thank you.
Sumit is
Thank
there
you.
for vote of thanks.
Yeah.
Sorry?
Thank you. Mr. Sumit, your question, your vote of thanks, please. You can go for final vote of thanks.
Thank you, Dr. Hani Al Samkari, for sparing your valuable time. It was an excellent presentation, and which was followed by a very, very engaging discussion. We have many good points from this wonderful presentation, and we are grateful to you for sharing your insights and expertise on HHT. On behalf of Zydus, I also thank Mumbai Hematology Group, Dr. M.B. Agarwal sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating the entire webinar in a highly proficient manner. Last but not the least, this series of webinars is possible only because of continuous support from perfect student team. So thank you to them. Thank you so much, everybody, and have a wonderful weekend.
Thanks a lot.
Everyone, and thanks again for the invitation. Really appreciate it.
Thank you, sir. And I thank all the discussants and the audience. Meet you tomorrow at 11:30 a.m. Bye-bye.